Legionnaires' disease is a severe, often life-threatening pneumonia caused by Legionella pneumophila, a bacterium that thrives in engineered water systems and spreads when contaminated aerosols are inhaled. While individual cases can occur sporadically, outbreaks often have high mortality rates, approaching 10% overall and exceeding 25% among hospitalized or immunocompromised patients. The disease's significance lies not only in its clinical burden, but in the complexity of its pathogenesis. Legionella exploits multiple interconnected systems, environmental reservoirs, aerosol physics, intracellular survival mechanisms, and host immune dynamics that can transition rapidly from silent containment to destructive escalation. These overlapping processes cannot be understood in isolation. They demand an integrated framework that captures both cause and effect relationships and the non-linear feedback loops that govern disease progression. This analysis treats Legionnaire's disease as a staged systems process, rather than a single event. Each stage represents a critical transition, from environmental exposure to alveolar seeding, from intracellular colonization to inflammatory ignition, from immune-driven injury to clinical pneumonia, and ultimately toward recovery or systemic collapse. At every stage, three interdependent elements define the local dynamics, typically representing a bacterial process, a host process, and an environmental or physiologic context. By framing these relationships as triads, we can describe not only what each element does, but also how they influence one another, reinforcing cycles, threshold effects, and points of instability that explain why disease either resolves or accelerates. To guide your understanding, each stage section is structured in a consistent way. The narrative introduction sets the clinical and mechanistic context, explaining where we are along the progression and why that transition matters. Next, the three-element sections break down the specific components of the triad, describing their biological roles, measurable signals, and contributions to the system's state. Finally, each stage ties these elements back together, showing how their interactions create the characteristic dynamic pattern of that phase and how they connect forward into the next transition. The analysis unfolds across 5 stages. Stage 1 covers exposure and alveolar entry. Stage 2 explores intracellular colonization and local amplification. Stage 3 traces the ignition of inflammation. Stage 4 examines the consolidation of clinical pneumonia. And Stage 5 addresses resolution versus complication. By combining narrative, mechanistic detail, and triadic systems logic, this framework builds a coherent view of how Legionella progresses from environmental exposure to severe disease. Equally important, it highlights where along this trajectory the process can be interrupted. Opportunities for prevention, mitigation, and improved clinical outcomes. The story begins in the environment, where Legionella thrives in engineered water systems and becomes dangerous only when disturbed into aerosols small enough to reach the deepest regions of the lung. These particles remain suspended, are inhaled, and bypass the upper airways to deposit in the terminal bronchioles and alveoli. At this early stage, there are no symptoms. The process is mechanical and probabilistic, determined by airflow patterns, droplet size, and breathing dynamics. What matters is not simply being near a source, but whether enough viable bacteria reach enough vulnerable alveolar units to create a foothold. The effective alveolar deposition of viable bacteria, the frequency of encounters with resident macrophages, and the ability of the organism to successfully invade those cells. Deposition reflects how much bacterial mass physically reaches the alveoli. Macrophage encounters represent the host's first attempt to clear those invaders. Successful invasion determines whether the bacteria establish intracellular niches rather than being destroyed. These elements work together to define whether exposure ends harmlessly or sets up the conditions for colonization. The dynamic arises because these 3 factors reinforce one another. Higher deposition seeds more alveolar units, increasing the likelihood of macrophage engagement. When those encounters cross a threshold of bacterial density, the chance of successful invasion climbs. Each invasion produces progeny that are released locally when host cells rupture, increasing the nearby concentration of bacteria and effectively boosting deposition for neighboring cells. The physics of aerosols sets the gate for this stage. but local biological amplification determines its slope. If enough units ignite early, the infection accelerates. At the heart of stage 1 is a simple but unforgiving equation: how much bacterial material actually makes it to the deepest recesses of the lung. Each inhalation carries particles along branching airways, and only those within a narrow size range, roughly 5 microns or smaller, bypass the body's upper defenses to reach the alveoli. This effective deposition is not fixed. It emerges from the interplay of environmental conditions, droplet physics, breathing patterns, and exposure duration. Turbulent airflow, humidity, and even posture shape where aerosols land. When deposition is sparse, most bacteria are cleared before they ever meet a host cell. But when enough particles arrive together, they seed multiple alveolar units simultaneously, increasing the odds that at least some will engage macrophages. Once early infections take hold, ruptured cells release bacteria back into their surroundings, raising the local concentration and effectively feeding back into this deposition term. A microscale amplification loop that can accelerate an otherwise improbable event. Every deposited particle lands in a neighborhood patrolled by alveolar macrophages, the lung's sentinels. These cells extend fine pseudopods, sensing and engulfing particles they encounter. But the outcome of these encounters depends on numbers, the multiplicity of infection, or MOI. At low MOI, macrophages tend to clear bacteria efficiently, dismantling them within acidified phagolysosomes. As the deposited load increases, however, these sentinels become overwhelmed. Above a critical threshold, the balance tips. More macrophages are simultaneously engaged, and more encounters occur under conditions that favor bacterial subversion rather than destruction. The efficiency of these interactions is shaped not only by bacterial burden, but also by the vulnerabilities of the host. Age, chronic lung disease, and smoking all degrade macrophage responsiveness, lowering the threshold at which clearance fails. Likewise, Legionella, arriving from biofilm-rich reservoirs or protozoan co-cultures, often carry enhanced virulence traits, making them harder to neutralize. When encounter rates climb past this tipping point, the stage is set for the next decisive step: successful invasion. For those macrophages that take up Legionella, the battle is far from over. The bacterium deploys its ICM type 4 secretion system, which is basically a molecular syringe that injects effectors capable of rewiring the host cell's internal trafficking. Instead of being routed to lysosomes for destruction, the engulfed bacterium remodels its compartment into a Legionella-containing vacuole, a protected niche that's actually linked to the cell's own endoplasmic reticulum. Within these vacuoles, the bacteria replicate largely undetected until the host cell ruptures, spilling progeny into the surrounding alveolar space. Each successful invasion then achieves two things. It converts a defensive macrophage into a replication factory, and it raises the local bacterial concentration for nearby alveolar units. This creates a reinforcing cycle, where early successes multiply opportunities for further success. In this way, invasion really represents the switch from passive exposure to active colonization, the point where mechanical risk transforms into a biological foothold. Once inside the alveoli, Legionella shifts from surviving the journey to exploiting the host cell. Alveolar macrophages, which are the first line of defense, engulf the organism intending to destroy it. But Legionella has evolved mechanisms to subvert this process. Within the captured compartment, it avoids fusion with lysosomes and instead constructs a protected vacuole where it can grow largely undisturbed. The clinical picture at this point often remains silent or subtle. The contest between bacterial expansion and immune containment is unfolding microscopically, but the balance struck here sets the pace for all downstream events. This stage revolves around three interconnected elements: the intracellular replication burden within infected macrophages, the integrity of the protective vacuole maintained through host pathway subversion, and the release of bacterial progeny through lytic egress into surrounding tissue. Replication drives the rise in bacterial load. Sustained vacuole remodeling allows that replication to continue unchecked. eventual host cell rupture disperses newly formed bacteria and damage-associated molecular patterns into the local microenvironment. These elements collectively determine whether colonization remains constrained or rapidly expands within the lung. The dynamics here are self-amplifying. As the intracellular burden grows, the need to maintain the protective vacuole becomes more critical. Effective subversion extends the host cell's lifespan long enough to produce a larger bacterial yield. Once the vacuole fails or replication overwhelms the host cell, lytic egress spreads bacteria to nearby macrophages and epithelial cells, resetting the cycle with more starting material at each round. Each wave of replication creates more opportunities for subsequent infection, which builds the stage's exponential character and primes the system for the inflammatory ignition that defines the next stage. Once Legionella establishes its protected niche, it turns the host macrophage into a replication factory. Within the remodeled vacuole, the bacteria siphon amino acids and lipids, hijack the host's translation machinery, and avoid autophagic clearance, steadily increasing their numbers. Early in infection, this burden remains modest, allowing the macrophage to function and sustain its role as an incubator. But as the bacterial population swells, the balance tip's rising burden places mechanical and metabolic strain on the host cell, nudging it toward programmed inflammatory death pathways such as pyroptosis and necroptosis. These processes not only liberate bacterial progeny, but also release danger signals into the surrounding tissue, setting the stage for the immune ignition that follows. A higher intracellular load thus has cascading consequences. It magnifies the need for vacuole maintenance, shortens the time to cell rupture, and fuels the local reseeding that accelerates spread. So, the success of Stage 2 really depends on Legionella's ability to control the battlefield inside the macrophage. Through its .ICM secretion system, the bacterium delivers a suite of effectors that transform the phagosome into a Legionella-containing vacuole, or LCV, cloaking it in endoplasmic reticulum-derived membranes and diverting host trafficking pathways to avoid lysosomal fusion. This protective compartment isn't static. As the bacterial burden grows, the vacuole needs to be continuously remodeled and defended against cellular mechanisms that try to detect and destroy it. If the pathogen fails to maintain this subversion, the vacuole collapses, and the host cell rapidly neutralizes its contents. But when the LCV stays intact, the macrophage basically becomes a stable incubator, producing larger bacterial yields and delaying immune detection. In this way, vacuole integrity extends the window of replication, ensures synchronized cell rupture, and maximizes the downstream impact of lytic egress. The culmination of Stage 2 arrives when the infected macrophage just can't contain its burden any longer. As replication peaks, membrane integrity fails, which triggers cell rupture and releases both bacterial progeny and a flood of damage-associated and pathogen-associated molecular patterns, DAMPs and PAMPs, into the surrounding alveolar space. This event, actually, has dual consequences. First, it reseeds neighboring macrophages and epithelial cells, exponentially increasing the number of productive infections and feeding right back into the cycle of replication. Second, it delivers an inflammatory spark. The debris and danger signals unleashed upon egress act as powerful alarms, priming complement activation, neutrophil recruitment, and endothelial changes that will soon define Stage 3. Here, lytic egress is more than just the dispersal of bacteria. It's the turning point where silent colonization threatens to become visible, accelerating disease dynamics and setting the immune system on high alert. When enough infected macrophages rupture and release both bacterial products and danger signals, the immune system accelerates from measured containment to full activation. Molecular sensors recognize pathogen and damage-associated signals, triggering cascades of cytokines, complement activation, and recruitment of immune cells to the lung. This influx, though designed to neutralize infection, becomes destructive. Neutrophils flood the alveoli, endothelial cells loosen, and vascular permeability rises. It's at this point that patients typically begin to show overt symptoms like fever, cough, malaise, and early shortness of breath, as localized injury escalates towards systemic involvement. This stage's behavior is shaped by three interacting elements: the activation of innate immune pathways via complement and toll-like receptors, the recruitment and activation of neutrophils with their potent degranulation responses, and the activation of the alveolar capillary endothelium leading to vascular leak. Together, these elements drive a lung-wide transformation chemical signals, summon immune effectors. Immune effectors damage both pathogens and host tissue, and structural barriers respond by becoming increasingly permeable. This phase really marks the turning point from microbial strategy to host-driven injury. The relationship among these elements is synergistic rather than linear. Early signaling through complement and TLRs amplifies neutrophil recruitment, while neutrophil degranulation and reactive oxygen species directly injure alveolar surfaces and release more endogenous damage signals, further intensifying immune signaling. At the same time, endothelial activation and leak allow greater immune cell influx, worsening edema and perpetuating recruitment. Once any two components are engaged, the third tends to follow, locking the lung into a self-reinforcing escalation loop. Without intervention, this stage accelerates the structural and physiologic disruption that makes clinical pneumonia inevitable. The ignition point of stage 3 lies in the host's molecular sensors, which detect both the pathogen's fingerprints and the collateral debris left by ruptured cells. Pathogen-associated molecular patterns, like Legionella's atypical LPS and damage-associated molecular patterns from dying macrophages, converge on pattern recognition receptors such as TLR2, TLR5, and TLR9. Their activation launches a rapid cytokine program releasing TNF-alpha, IL-1 beta, and IL-6, while complement pathways generate potent mediators like C3A and C5A. Together, these signals set the stage for full immune recruitment. Adhesion molecules are upregulated, the endothelium becomes more permissive, and neutrophils are primed for activation. Importantly, this arm doesn't operate in isolation. Once complement and TLR pathways are triggered, they lower the activation threshold for the other components of the triad. With either neutrophils or endothelial leak already engaged, the loop closes, and the inflammatory cascade accelerates almost automatically. Neutrophils are the shock troops of the immune response, summoned into the alveoli by chemokines and complement-derived signals like C5A. Their arrival is rapid and their weapons are potent granules packed with elastase, myeloperoxidase, proteases, and reactive oxygen species. While these tools are effective at killing bacteria, they are blunt instruments in delicate tissues. Neutrophil degranulation damages alveolar epithelium and capillary endothelium, rupturing membranes and spilling intracellular contents into the local environment. This amplifies DAMP signaling, reinforcing the activation of complement and TLR pathways, which in turn recruits even more neutrophils. The result is a spiraling feedback loop where the very cells intended to control infection become primary drivers of tissue injury. As damage accumulates, the structural integrity of the alveolar capillary barrier erodes, setting up the hypoxemia and radiographic consolidation that will soon define stage 4. The alveolar capillary endothelium, normally a selective and tightly regulated barrier, becomes a critical amplifier of pathology in this stage. Cytokines, complement products, and neutrophil-derived mediators act in concert to activate endothelial cells, causing them to express adhesion molecules, contract their junctions, and increase vascular permeability. Plasma proteins leak into the alveolar space, promoting edema, while immune cells are granted easier access into tissue. At first, this may seem beneficial. Enhanced recruitment provides more immune effectors to the battlefield. But the trade-off is steep. Accumulating edema thickens the gas exchange interface, impairs oxygenation, and feeds further injury by intensifying DAMP release, which in turn drives signaling and recruits more neutrophils. Once vascular leak is established, the inflammatory circuit stabilizes into a locked-on state, and the lung becomes progressively flooded with both immune cells and protein-rich fluid. Without interventions to dampen at least one component of this triad, the transition to overt pneumonia in stage 4 becomes inevitable. At this stage, the underlying structural and inflammatory damage becomes unmistakably visible. The alveolar capillary barrier has been compromised, fluid and proteins flood the alveoli, and effective gas exchange breaks down. Patients develop worsening hypoxia, tachypnea, and respiratory distress. Imaging begins to show patches or lobes of consolidation, and systemic signs intensify with fever, malaise, and electrolyte derangements. The clinical syndrome now emerges clearly, where pathologic processes previously invisible to the patient and clinician produce recognizable patterns and testable findings. 3 domains shape this consolidated phenotype: disruption of the alveolar capillary barrier, impairment of gas exchange caused by exudate and alveolar collapse, and the development of radiographic and clinical pneumonia recognizable at the bedside. Barrier injury underlies all else, as it sets the conditions for shunting, edema, and poor oxygen transfer. Gas exchange failure transforms these microscopic injuries into measurable physiologic decline, while diagnostic confirmation integrates systemic, imaging, and laboratory signals into a coherent clinical picture. The triadic interplay here is sequential but stabilizing. Barrier damage drives impaired oxygenation, and as oxygenation worsens, the probability of radiographic consolidation and clinical detection rises sharply. Once diagnostic confirmation occurs, through imaging, antigen detection, or PCR, the syndrome is anchored in both perception and management. Clinical teams integrate systemic response, local pathology, and laboratory confirmation into a unified framework. By the end of this stage, the disease has declared itself, and the trajectory into stage 5 is determined by the timing and effectiveness of intervention. Stage 4 begins with a structural failure. The delicate interface between the alveoli and pulmonary capillaries, once tightly regulated, becomes progressively compromised under the assault of neutrophil-derived enzymes, reactive oxygen species, and cytokine-driven inflammation. Tight junctions loosen, membranes break down, and protein-rich exudate floods the alveolar spaces. With each breach, the barrier thickens, increasing the distance gases must diffuse and further straining oxygen transfer. Even before a patient feels short of breath, this disruption is reshaping the lung's architecture, laying the groundwork for hypoxemia and consolidation. Without this structural injury, the rest of the cascade cannot unfold. Barrier integrity is the indispensable prerequisite for clinical pneumonia. As barrier injury accumulates, its physiological consequences become unavoidable. Proteinaceous edema, collapsed alveoli, and inflammatory exudate create severe ventilation-perfusion mismatch and intrapulmonary shunting, where blood bypasses oxygenation entirely. The diffusion barrier thickens just as perfusion patterns become chaotic, causing progressive drops in PaO2 to FiO2 ratios and forcing patients to breathe faster and harder to compensate. At the bedside, this is where clinicians begin to see tangible shifts: rising oxygen requirements, increased respiratory rates, and widening alveolar arterial gradients. Impaired gas exchange is the bridge between silent structural injury and overt clinical disease. The more oxygenation falters, the higher the likelihood that radiographic changes will consolidate and symptoms will escalate, drawing stage 4 into full view. When the microscopic disruptions of stages 2 and 3 finally converge, the syndrome becomes visible. Consolidation appears on chest imaging, often first as subtle ground glass changes that evolve into patchy or lobar opacities. At the same time, systemic signals amplify fever, malaise, hyponatremia, and rising inflammatory markers mark the body's escalating response. Diagnostic confirmation, whether by urinary antigen, PCR, or culture, unites the physiologic, imaging, and laboratory threads into a single, coherent diagnosis. Once confirmed, the disease state is locked in both biologically and clinically. Local injury, systemic inflammation, and radiographic evidence reinforce one another, accelerating decisions about therapy and supportive care. Without the structural breakdown and oxygenation failure, pneumonia does not materialize. But once C emerges, the disease has fully declared itself, and the next stage is determined by how rapidly and effectively intervention begins. With pneumonia established and the host in a systemic inflammatory state, the outcome hinges on whether effective therapy arrives soon enough. and insufficient force to reverse the course. If antibiotics with intracellular activity are administered promptly, bacterial replication halts, inflammatory cascades begin to subside, and the lung gradually regains functional integrity. Supportive care complements antimicrobial action, stabilizing oxygenation and mitigating systemic stress. But if treatment is delayed, inadequate, or undermined by patient vulnerability, bacterial expansion persists, immune injury worsens, and the risk of cascading organ dysfunction increases. This stage integrates three critical factors: the timeliness and adequacy of intracellular active antibiotic therapy, the rate of bacterial clearance achieved in response to treatment, and the trajectory of inflammatory resolution versus complication risk. Effective antimicrobial therapy enables bacterial kill, which reduces inflammatory fueling, allowing supportive interventions to restore physiology. Conversely, a slow kill slope or incomplete pathogen suppression sustains the inflammatory drivers of respiratory failure, sepsis, and multi-organ compromise. The relationship among these elements defines the tipping point between recovery and decline. Timely, targeted antibiotics drive rapid bacterial clearance. This clearance reduces immune activation, improving gas exchange and lowering complication risk. Supportive care amplifies this effect by addressing hypoxia, electrolyte disturbances, and systemic consequences of inflammation, creating a synergistic recovery pathway. But failure at any step reverberates across the triad. Inadequate therapy blunts bacterial decline, unchecked inflammation undermines organ stability, and mounting complications overwhelm reserves. At this final stage, the system either converges toward resolution or spirals into irreversible injury. The first lever of recovery is time. Legionella resides inside macrophages, and clearing it requires antibiotics capable of penetrating the Legionella-containing vacuole and maintaining sufficient intracellular concentrations to halt replication. Macrolides and fluoroquinolones provide this activity, but their effectiveness depends on how quickly they are given and whether dosing achieves adequate tissue penetration. Each hour of delay extends the window during which bacterial populations expand and immune injury compounds, making recovery less likely. Selecting an agent without intracellular activity has a similar effect. The therapy arrives but fails to reach the battlefield. Here, timing and drug choice converge. Appropriate early antibiotics are the switch that activates the rest of the resolution cascade. Without A, there is no steep bacterial decline and no meaningful opportunity for downstream recovery. Once effective antibiotics are in place, the pace of bacterial clearance becomes the next determinant of outcome. A steep kill slope, a rapid log-scale decline in bacterial burden, halts local reseeding, cuts off the fuel for cytokine release, and removes the triggers sustaining neutrophil-driven injury. When therapy works quickly, the momentum of stage 3's inflammatory escalation begins to reverse, oxygenation improves, and the physiologic stress on other organs eases. But if clearance is slow, because of subtherapeutic dosing, delayed initiation, or impaired immune contribution, bacterial replication continues to feed immune activation, preventing inflammatory regression. In this way, the kill slope acts as the mechanistic bridge between treatment initiation and clinical improvement. A shallow slope signals persistent risk. A steep slope signals the lung's first opportunity to recover. The final outcome rests on whether inflammation resolves in step with bacterial control. As the burden falls, cytokine levels decline, neutrophil degranulation slows, and endothelial leak begins to repair, allowing gas exchange to improve. Supportive care amplifies this recovery. Supplemental oxygen addresses hypoxia, fluid and electrolyte correction stabilize systemic physiology, and careful monitoring mitigates secondary stresses on the heart, kidneys, and brain. When bacterial clearance succeeds and therapy is timely, inflammation retreats and the lung begins to restore its structural and functional integrity. But if regression stalls, if oxygenation fails to improve, CRP levels plateau, or organ support requirements intensify, it signals unresolved drivers. At that point, the triad must be reassessed. Inadequate therapy, insufficient bacterial decline, or persistent immune amplification may all be culprits. Without coordinated control, complications accumulate, worsening respiratory failure, septic shock, and multi-organ dysfunction. This is where the system either converges toward resolution or slips beyond recovery. Legionnaires' disease unfolds not as a single event, but as a dynamic systems process, where bacterial strategies, host responses, and environmental factors interlock through a series of reinforcing and branching pathways. Across 5 stages, we have traced how subtle exposures in the environment become amplified within the lung, how silent intracellular colonization transforms into an uncontrolled inflammatory cascade, and how immune-driven injury culminates in clinical pneumonia. The trajectory does not end there. Stage 5 demonstrates that even once the disease has declared itself, outcomes are still negotiable, hinging on timely recognition, effective therapy, and supportive stabilization. A central insight from this framework is that triadic relationships govern every critical transition. Each stage is not defined by a single driver, but by 3 interacting elements, typically combining a bacterial process, a host response, and a physiologic or environmental context. These triads reveal why the system behaves non-linearly. Small changes at one node can propagate through reinforcing feedback loops, producing rapid escalation, while targeted disruption of a single element can sometimes collapse the entire cascade. Early deposition shapes macrophage encounters and invasion. Intracellular replication demands sustained vacuole control but drives lytic reseeding. Immune activation recruits neutrophils that both protect and injure. Barrier disruption worsens gas exchange, locking in pneumonia. And therapy success or failure pivots on whether antimicrobial timing, bacterial clearance, and inflammatory regression align. By understanding these triads, we move from describing events to explaining dynamics. Equally important, this systems view highlights intervention points across the trajectory. Prevention begins upstream, by controlling aerosol generation and environmental reservoirs. Mitigation operates during early stages, where limiting bacterial burden or enhancing macrophage clearance can abort progression before inflammation ignites. Once stage 3 begins, countering endothelial leak, modulating immune overactivation, or maintaining alveolar stability can still alter the slope toward clinical consolidation. Even in established pneumonia, timely intracellular active antibiotics, rapid bacterial clearance, and optimized supportive care can redirect the path toward resolution and away from organ failure. Across these opportunities, the triads act as guides. They map where control can be gained and where it is most easily lost. In sum, Legionnaire's disease represents a paradigm of intersecting biological, mechanical, and clinical systems. Its pathogenesis is not just a sequence of events, but a structured set of interdependencies that amplify, branch, and sometimes self-correct. Understanding these dynamics transforms management from reactive treatment of visible symptoms into anticipatory control of hidden processes. The framework outlined here provides not only a narrative of progression, but a scaffold for prediction, measurement, and targeted intervention. A way to see the whole system and identify where a single well-timed action can shift the entire trajectory.